Our next panel speaker is Hamid Faruqi, who is from UAE and who is known endocrinologist there back in UAE. He's a founding member of Pakistan Endocrine Society. So he will be talking on international standards, local solution, running a diabetic clinic in resource limited setting. So Professor Hamid Faruqi.
Good morning, everyone. I'm Dr. Hamid Faruqi. I'm a consultant endocrinologist, and I am the director of Dubai Diabetes Center here in the UAE. Today, I will be sharing some ideas about a structured approach to delivering diabetes care in rural areas of Pakistan. Despite the scarcity of resources, we can implement sustainable models of care by adapting international standards to local realities. So, starting with the name of Allah, Bismillah ar-Rahman ar-Rahim, these are my disclosures. So, what are our key objectives today? These include reviewing international standards for diabetes clinics, identifying essential tools for effective care delivery, understanding the specific challenges faced in rural areas, and finally discussing scalable, cost-effective local strategies that have shown promising outcomes. Here is a quick roadmap of our talk. We begin by discussing the magnitude of the diabetes problem in Pakistan, then clarify why urgent action is needed. We will then define our clinical objectives, explore challenges in rural healthcare delivery, and present a phased approach to implementation. We will conclude with insights on monitoring, evaluation, and sustainability. So, what is the magnitude of the problem? As you know, Pakistan has the world's highest prevalence of diabetes. It ranks third in the total number of adults with diabetes after China and India, which have, as you know, a population of billion or more. There are 30 million or more affected individuals in Pakistan. Shockingly, more than one-third are undiagnosed. This implies that millions are progressing towards complications silently. Projections show that the population with diabetes may reach 62 million by 2045. This emphasizes the critical need for early detection and structured care interventions. So, why address it? As you know, diabetes is a silent killer. Without timely intervention, it leads to serious complications such as cardiovascular disease, kidney failure, blindness, and amputations. This contributes to both mortality and immense disability. As you can see, these complications set in quite early in the course of disease. Hence, early proactive care can significantly reduce this burden both on the patients and the healthcare system. So, what is our objective? Our dual objective is early intervention and complication prevention. Diabetes clinics should guide newly diagnosed patients by providing structured education and coordinate care through a multidisciplinary team. Equally important is early screening and management of complications. Where such services aren't directly available, clinics should establish efficient referral systems. According to the guidelines from our own Pakistan Endocrine Society, easily available from this website that you have in our screen, as well as other international entities such as ADA and IDF, an ideal diabetes clinic should offer team-based care, evidence-based protocols, and essential diagnostic tools such as hemoglobin A1C, lipids, and renal parameters. Education must be structured and focused on self-management. All care should be documented, ideally through an electronic medical record, which may not be possible everywhere. So, at a minimum, there should be structured paper records. Finally, periodic audits and quality checks are essential for improving care. Then we will be talking about all of these in the next few slides. So, what are the goals of a diabetes clinic in resource limited settings? In rural or low resource settings, we must adapt but without compromising outcomes. So, this includes using standardized protocols coming from the guidelines that we mentioned earlier. There should be some task sharing among staff, which then these staff should also be trained, and we will talk about it in a second. We need to provide group-based education so that we can cover more people over the same time, and also to have a sustainable operational models. That means that we can keep this clinic going over a long period of time. Prevention through community education and regular screening of high-risk individuals is also crucial to reduce the long-term burden. So, what are the challenges in these rural settings and what are the possible solutions? The healthcare faces many obstacles. There might be limited access to trained healthcare professionals, inadequate lab facilities, strong cultural belief that may impede care-seeking behavior. Affordability and lack of transportation further exacerbate access issues. Moreover, the absence of structured referral system and digital record keeping, as we mentioned, makes the care fragmented and less effective. So, now coming to establishing the center itself, phase one would be to set up the clinic itself. We propose that we renovate a section of an already existing healthcare facility rather than spending money on creating a facility from scratch. This would help us save some costs. The essential staffing includes a trained physician who could be part-time if necessary. We need 1 or 2 trained nurses, but they have to be trained in diabetes care. And how we can get that training? Again, we will touch on that in a minute or so. We also need to have a lab technician so that the basic labs that we mentioned earlier, such as the hemoglobin A1C, can be performed at the site itself. We must also mobilize local lady health workers who are already there serving the community. This foundation will allow us to have a better patient intake early on and also the basic diagnostics to begin with. As I mentioned, staff training is extremely important. So we need to use whatever materials that are available to us both locally, and we can tap into international resources as well. We can also do some on-site training as well as the online CME. We can get mentorship from tertiary centers and also focus on community engagement so that people don't feel stigmatized to come to a diabetes center. So what are the available resources? I told you about the ADA, which in fact has a professional education library where we can get these free recorded webcasts. There is the Standards of Medical Care in Diabetes that gets published every year that is available free online, and there are also audio podcasts. International Diabetes Federation does have, as some of you might know, an IDF school for diabetes that offers free basic courses for healthcare professionals, and they cover topics such as foot care, gestational diabetes, and complication management. Then there is a whole professional development arm also available. Locally, Pakistan Endocrine Society is a great resource, and we have talked about the guidelines which are in detail and are available. Similarly, Diabetes Association of Pakistan and other local and regional entities are available to you. In addition to that, there are multiple other institutions such as the CDC's National Diabetes Education Program, the World Health Organization Diabetes Program, American Association of Diabetes Educators, the National Institute of Diabetes and Digestive Kidney Diseases, Joslin Diabetes Center, my old alma mater, and also Stanford University's Endo Hub. So all of these are available to us in this day of internet and web access to get free education from all these resources. The second phase is that of clinical service implementation. Once the center is established, the core services should begin. These include, as I mentioned earlier, point of care diagnostics like glucometers and hemoglobin A1C, initiation of treatment based on essential drug formularies and screening for complications like foot ulcers and also checking for proteinuria. We need to find the complications as early as possible. Education should be integrated from the first day onward. Outreach through village screening camps and home follow-ups by lady health visitors can enhance access as well as follow-up for our patients. The next phase is that of education and support systems. We must adapt education to local context, bringing in educational material that were designed for other cultures and other societies are of no help. So, this means, therefore, using simple pictorial ads for low literacy patients and scheduling separate sessions for men and women. Group sessions build peer support and reinforce behavioral change. We can also include or introduce glucose diaries, visual medication charts, and also engage family members in care, especially in the joint family systems. These are ideas that can help maintain the level of care for a long period of time. The next phase has to do more with the operations side of such a clinic. And this means the sustainability as well as day-to-day operations. So sustainability depends on sound operations. A steady supply chain of essential medicines is crucial. We need to create stock storages so that we don't run out of these critical medications by realizing that we don't have them at the last moment. And for that, we need to develop a simple inventory management system that tells us what the stores are looking like at this point in time. With regards to the financial model, which is the Achilles heel of any such center, we need to come up with ideas of payment systems based on economic capacities. Wherever we have government programs, we need to utilize that. And finally, we should encourage the wealthier segments of population who are utilizing the center to help contribute towards the management of our poorer patients. In terms of the medications, Pakistan has a national list of essential medications, which, as you can see here, includes insulins of various sorts, such as the long and short-acting insulin, pre-mixed insulins, and oral hypoglycemic agents. At the minimum, metformin, sulfonylurea, and SGLT2 inhibitors, and some other agents such as glucagon for treating severe hypoglycemia, because you will have type 1 patients coming to the clinic. So, with regards to the access to insulin, we do know that there have been major steps that have been taken just in the recent past. There is now a free insulin program, a Chief Minister's free insulin program in Punjab, which we should be aware of. And Meethi Zindagi under Dr. Atif has done quite a good work in that regard. Similarly, we have the KPK government free insulin program, and I salute Dr. H. Ahmed for that and his team. We also have NGOs such as the Huwat Foundation and the Changing Diabetes in Children program that are there that can help us gain access to free insulin for our patients with type 1 in general and type 2 as well that need insulin. The next phase is that of community integration. Please remember that any such center in the rural area cannot work in isolation. We need to have community engagement, which will ensure long term acceptance of this center. Forming an advisory committee with the village elders and local influencers will foster trust. Religious leaders can help immensely by promoting healthier behavior through their platform in the masajid. Schools can serve as hubs for early education and screening. Community volunteers can be trained as diabetes champions to lead local initiatives and peer support. We can ask our medical colleges in the region for visiting specialist support. Our local pharmaceutical distributors can help us with reliable supply chains. And as I mentioned, the professional societies such as the Pakistan Endocrine Society are of great help in this regard. The local health authorities will also be crucial in making these diabetes centers in the rural areas successful. These are the days of technology. As you can see, most people now have smartphones and have access to lots of apps. So it's not necessary that they should spend time on TikTok or Instagram. There are medical health apps that are crucial for people to be gaining the proper knowledge and also for follow-up. Same technology can be leveraged to support appointment reminders and sending out educational messages. We are all aware of teleconsultations, and we can utilize this technology to connect with the specialists in urban areas. Remote monitoring using Bluetooth enabled devices can help monitor the patients who cannot come to us on a regular basis. And all these technologies, including simple EMRs, can be used in these settings. And believe me, the costs have come down significantly with regards to technology that we can use. Now, no center can tell how good or bad it is doing without certain performance indicators. These can be simple, such as the number of patients that are being followed up, number of new patients, how much the hemoglobin A1C is improved, what are the complication detection rates. Again, we can also run, or we should also run, satisfaction surveys that tell us how good we are doing. And finally, a simplified paper record system, if electronic medical record is not possible, is something that is key in terms of knowing how we are doing in the long run. Next comes the budget. We are going to have an important role of budget in terms of the initial setup costs, which includes the facility renovation, equipment, training, medications, which are your capex or capital expense, and then after on your ongoing expense for the salaries, for the supplies, and things of that nature, which is called the OPEX. You definitely need to have an implementation timeline. So for the first few months, you need to do the preparation and the procurement, recruitment of staff, the training, and the development of clinical protocols. The next 3 months, you need to start a soft opening with some basic clinical services, initiate lady health worker training, and also start registering patients. The next 3 months, you should move on to full service implementation, outreach program expansion, and in the next year, you can look for technology integration and then move out to smaller satellite locations if that is possible. So to conclude, these are our keys to success. Start with the essentials, integrate culturally, and build capacity, leverage the technology appropriately, measure the progress, and engage the stakeholders. Finally, I would encourage everyone to think big and aim for a comprehensive cardio-renal metabolic center which can cover all aspects of diabetes. Alhamdulillah, we are trying to build one here, as you can see, and inshallah it will open next year. And this is our team that is making it possible. So I thank you everyone for your time, and inshallah, we will be in contact again. Thank you very much.
Okay, if there is any question for Dr. Hamid Faruqi, we can take one or two questions. Okay, so my next speaker is Professor Muhammad Noor Wazir, who is uh, Dean and Chief Executive Officer of Postgraduate Medical Institute, Hyderabad Medical Complex, and Professor of Medicine at Khyber Girls Medical College, Hyderabad Medical Complex. So he's going to talk about the new concept, artificial intelligence and endocrine setup. So this is something new, whether it's reality. So give a back clap.
Bismillah ar-Rahman ar-Rahim. Rabbi sharah li sadri wa yassir li amri wa hlul uqdatam min lisani yafqahu qawli. Two things I want to say it in the very beginning. Number one, I apologize for the talk to be a bit boring, because the real forum for talking about these apps, when you fiddle with it in real time, rather than taking a screenshot and projecting it as a still, model. So that interest gets diluted. But anyway, we will try to compensate. Number one. Number two, it is a buzzword and a very extensive topic. I don't anticipate that you are going to learn and cover everything what we discuss in a second, but it should be an eye-opener, because some of us are immigrant to the net and computer era, while the others are, say, Gen Z. They might be able to cope well with the evolving thing. I think most of you would know these two guys. The one to the right, unfortunately, he has died. And the one to the left, he is still alive. And in 2023, he resigned from Google on the pretext saying that he has paved path to extinction of human race. Now, what is artificial intelligence? Artificial intelligence is either a software or an entire computer which perform a task that would typically need a human wisdom and intelligence. And it can act, think, and reason like a human being. And this is the main difference between a search engine and artificial intelligence. In search engine, when it is programmed for a particular topic, it will be able to do that task. But anything which you ask for pre-programmed, they would say no answer found. You give, something, a search box in the PubMed, it would say no result found. Unlike this, this will not happen with artificial intelligence. Now, a few other, definition before we dive deep. It is machine learning. Now, first, how do we learn? We have got receptors, auditory receptors, visual receptors, tactile receptors. So we take the stimulus. That stimulus goes to the brain. The brain processes and it gives you an output. Now, taking this thing into mind, the question was, can a computer learn something? Yes, the answer is yes. So a lot of data is fed into the computer, right? Trillion, like in ChatGPT 4, I feel it is around 4 trillion data has been fed into the computer. Now, there is an algorithm inbuilt in the computer to process the data, and that is usually on prediction. There may be regression, and we are not going to go into the details because we are not going to make something, an algorithm, etc. But you should know the basic concept. So there is a large amount of data. There is an algorithm based on prediction, and whatever input you give it to the computer would search that data, process it, and would give you an answer. So this is the basic concept of artificial intelligence. Now, what is a large language model? A large language model, trillion of data has been fed into the computer, and it gives you either visual or voice or textual, like ChatGPT, DeepSeek. ChatGPT is very good, large language model. It will give you a reasonably good, answer, but in textual or in a speech way, right? It is not built for picture. If you try to upload, a CT scan or an MRI, it is not as good. For that, there are different apps. So in large language model, it is basically used for voice or textual, conversation. And what is deep learning? Now, in deep learning, you have got an input. The computer, processes that data, and depending upon the complexity of the task, there are multiple layers. There may be in 100 and 1,000 layers, right, with interconnection between the output and the input. So there are multiple, layers depending upon the complexity of the task. And this is the feature of a deep neuronal learning. There may be convolution in it. Now, ChatGPT or DeepSeek, these large language models, they are working on this deep learning. Now, what is a natural language processing? Enabling the computer to understand, interpret, and generate human language. We are not, using Java, .NET, or PHP. The computer talk to us like we are talking to each other. Or when we are texting to the computer, also generates an output in the form of the text rather than coding, etc., etc. This is what natural language is. Right? And a chatbot simulates human conversation with an end user. So a chatbot will chat either in the form of voice or textual message. Before we dive, these two, rather three, one is narrow generative AI. And what is the word generative? We say a lot about ChatGPT. GPT is generative. Whatever it generates, this is actual. It is not there before in any, net, book, journal, etc. Whatever text it generates, it's original. You take it, place it in an eternity, there will be zero plagiarism. But yes, if you check it for AI, it would say AI generated, right? So in narrow generative artificial intelligence, the software is trained for a particular task, and it would do that particular task outside its ambient. It will be dull. It will not be. I'll give you an example. AlphaGo, many of you would remember, it is a software of chess, and it has beaten the world chess champion. But AlphaGo was asked to make a cup of tea, and she could not make the recipe of making T. So we are currently in the era of narrow artificial intelligence. ChatGPT, DeepSeek, and others, they are part of the narrow artificial intelligence what we are currently now. Now, when it becomes general, when it becomes multitasking, multifaceted, and it will be able to do things, there is a lot of data in the world. There are voices, there are cameras there. If it get access to all that data and process it, say for instance, the software is told how to create peace in the world. And the answer ultimately comes that human beings are the number one, player in disturbing the world peace. Let's kill all of them. And it has got access to all the atomic, this and this. That is multifaceted, etc., etc. And probably this what Jeffrey Hinton is thinking about, that he has paved a path to human extinction. Now, what are the duties? We will dive into what are our duties. We are taking care of patient, we are teaching, we are doing research, and at every stage, artificial intelligence can help you. Now, these are, a few tools in research. In qualitative, we try to use Utter AI, Perplexity, ChatGPT. For quantitative research, it is Consensus, SciSpace, Elicit, Connected Paper, Research Rabbit, Ask CSV. But these were, for research. We will restrict ourselves to patient care and particularly to endocrine, practice. Now, this is a software developed, recently and introduced in 2023, right? And the good thing is it is free. It is free. ECG GPT, right? You take a picture from 12 lead ECG, upload it, and it will generate an AI. And to give you my personal experience, one of my friends, some of you would know Brigadier Hayat. He was electrophysiologist in FIC. He has retired from there. He has made a WhatsApp group, and every week he uploads one ECG, right? For teaching purposes. And the ECGs are pretty tough ECGs. And I regularly upload those ECGs. On this one, or believe me, 19-20 का फर्क भी नहीं होता. So you can use it yourself, but most of you are seasonal clinician. Probably you don't need it. You know how to interpret ECG, but you can tell your juniors, right? Similarly, it is free of cost. इसमें आपके पैसे भी नहीं. You can place it as an app on your mobile, and you get an ECG uploaded. The best database so far, it is up to date, trusted, right? Has got links with so many societies. They have recently introduced the clinical decision support system, which is driven by artificial intelligence, uses the database of up to date. So all you need is to feed the patient information into this, and it will give you about the possible diagnosis, differential diagnosis, treatment, complication, and the treatment option. But there is a big but. Up to date, if you get it on donation or as a personal subscription, this is not part of the package, which is going to cost you something $350. This part is particularly there in the institutional, subscription, which is $9,000 per year. So, a good thing, but if your institution has got institutional subscription, you can use it, but you have to put, the data of the patient into the software, and it will help you in a clinical decision, making for the patient. Now, this app, DXGPT, a good thing is it is free, although not very accurate, I must say. But for your trainees and for house officer, it is very good for the, this. All you need is you will have, this software. You upload, the patient detail, and I'll show you. This is a patient. I have just stated 20-year female presented with feeling of being unwell, pulse 80, blood pressure 120, 80, temperature normal, BMI 20, rest of the examination, fundoscopy normal, fasting blood sugar 200, HbA1c 9, LFTs, RFTs, cortisol, TSH, ferritin normal. Please tell me the diagnosis. There is a very strong family history of diabetes, right? And this is the answer. Says, type 2 diabetes, moody. But when you go to the advanced model, right, again, the advanced model is on payment, but it gives you a lot of tokens. And moreover, आप पाकिस्तानी स्टाइल करें, 2-3 ईमेल ये नए एड्रेसेस बनाए और डिफरेंट ईमेल एड्रेसेस के थ्रू लॉग इन हो जाए, ठीक है ना. इट विल सर्व योर पर्पस, सेविंग यू मनी. सो इफ यू गो on the advanced model, it further refines, the answer. Probably time is short, we will not be able to go through. So at the end it says, if the most likely to be moody, if the person has got moderate hyperglycemia, absence of ketosis, lack of insulin resistance. So those things which are the most important, they are on the top, and the one which are least important, they are down on the bottom, right? The same thing. So it dissects for you the patient information through artificial intelligence, and the good thing is it is free, right? Watson Health, it is a very good software. In up to date, you have to place the information, but this can be linked to the electronic medical record of the patient. It will pick up through the natural language processing the patient information, lab data, and it evaluates. Like, if I say this is a 60-year-old male with type 2 diabetes presented to routine follow-up, the electronic health record shows HbA1c rising from this to this, EGFR declining from 75 to 55, and ACR has gone up, patient has missed 2 appointment and not on, this. So Watson would, synthesize these information, would place, a red flag, recommend initiation of the SGLT2, blah, blah, blah. You can try it at home, Watson AI at home, and it is you can integrate it if you have got electronic record of the patient, right? Moreover, if the person has got wearable devices, etc. Similarly, if your notes has got smoking, it will pick up through the natural language processing. We said the computer learns human, language. So it will pick up comorbidity, and the good thing is that it will give, ICD-10 codes as well to each diagnosis which is there in the patient. Very quickly, thyroid has been used very frequently by radiologists and diabetologists, and it has got several parameters, right? The consistency of nodule, margin, etc., etc. Now, every time, don't you refer this patient to radiologists to calculate, the score, whether the person would need watch and see FNAC or not. But this, machine, it is a probe with an ultrasound with inbuilt, this AI, you just take the probe, put it on the nodule, it will take all those information, process it through the artificial intelligence and would tell you what to do. Weight, FNEC, no, what are the chances of malignancy? So it's simple, make the thing simplified. So all you need is put the probe, put the lab results and patient parameter. AI algorithm will analyze and would give you a diagnosis. Similarly, wearable devices, very commonly used in diabetes, the continuous glucose monitor and the pump. Now, it has been, incorporated these two and it has been approved by FDA, right? So the two things, continuous monitoring as well as this Dream Med and similarly, Glytec Glucomander, again FDA approved, right? This is another, app which you can use. And very commonly, you take a photograph of the retina, dilate, this, and then you assess. While this camera, it has got artificial intelligence. It can take, the patient parameter, predicts is there any retinopathy or not, what you want to do, whether you should refer the patient to ophthalmologist for this and this. So no need for anything. And the 87.2% is the sensitivity and 90.7 is the specificity compared to the trained ophthalmologist. Similarly, AI, you can use it in endocrine education, right? There will be issue. This is one I have made as an AI via Zapier. It is an AI agent. You can make one for free on that platform, right? You see, the chat says, this is a chat bot, I have made it. I have been feeling quite fatigued lately, doc. The main thing that brings me today is ongoing fatigue, blah, blah, blah. Along with that, I have noticed a bit of weight loss without trying. My appetite is good, right? I think time is out. So it is a long chat, and ultimately we came up with the diagnosis of post-viral thyroiditis, right? So you can place it if Endocrine Society has got a learning management system, you can place those chatbots on your platform for the patient education, for the teaching of your PGs as well. This is that long chat we have done, and this is that Zapier. It integrates several softwares together, and one chatbot you can make it free on this platform. Similarly, history writing, kitni cumbersome cheez hai. This, freed, it is going to transcribe, the history entirely for you on SOUP protocol, subjective, objective assessment and planning. So everything is there in front of you, you copy it. So if I have, probably I haven't got time.
Thanks, Professor Noor, for an excellent presentation. We will take the question later on. So the next speaker is Professor Adnan Yar Khan, who is online. He will talk about hyperparathyroidism. Can we meet global standard in Pakistan? So Professor Adnan Yar Khan.
Bismillahirrahmanirrahim and Assalamu alaikum. Very good day to all my senior colleagues and distinguished members of Pakistan Endocrine Society. First and foremost, I would like to express my sincere thanks to the organizers for giving me such a prestigious platform. Though I may not be with you in person, it's a privilege to share these thoughts with you. And my topic for today's presentation will be the changing face of hyperparathyroidism. Can we meet global standards in Pakistan? From the surgeon perspective, I will be just more mainly talking on minimally invasive parathyroidectomy. I am Dr. Adnan, working in Hyderabad Medical Complex as a head and neck surgeon and surgical oncologist. My main this interest area is thyroid and parathyroid, and recently I'm working mainly on the pediatric parathyroid cancers, while this is my work which I will present today. This is my disclosure. I will start with an historical article published in Journal of Urology in 1984 by Harry M. Spencer from the Department of Urology, University of Texas. And this is the story of Charles Martel. The first picture in 1918, at that time he was 22 years old. He was in the US Navy, a fit man. At that year, he developed flank pains, milk urine with gravules, and later on losing his height, became pigeon-chested, multiple fractures with minimal injury. And up till 1926, the second picture is of 1926 when there is a hunchback and with the multiple deformities. In between that time, he was seen by many physicians in different places for his health care with an ailment which has no diagnosis. He was seen by Dr. Eugene Dubuis. He was the first metabolic investigator in the country, and he opened the first metabolic ward in the country as well. So he observed high serum calcium level and more urine calcium versus ingested amount. And he concluded that Captain Charles has an overactive parathyroid gland. He was later transferred to Massachusetts General Hospital, where he was explored 6 times with no results for parathyroid adenoma. In between that time, he used to go to the libraries, study anatomy books, and in these, he studied all the parathyroid system. And he was convinced that there is an overactive parathyroid gland somewhere in his mediastinum. At that point, he by himself requested for mediastinal exploration. And on mediastinal exploration, they found that there was a tumor. When the tumor was removed in the first month, just at the end of the first month, his calcium levels became normal. He was able to walk around. But unfortunately, later in 6th week, he died because of the urosepsis. So, but his experience ushered in an era where we started diagnosing hyperparathyroidism and treating hyperparathyroidism, still after 9 decades. So we follow the same trajectory that was in his case in 1932. So I found this story very interesting, this article, and I just watched this in one of the grand round by Dr. Subarna Dhaital, who is an endocrinologist in University of Wisconsin. So this is a very inspiring story, and just for all of residents and new fellows. For a surgeon, anatomy is of prime importance. We know there are 4 parathyroid glands. They are posterior to the thyroid lobes, 2 superior, 2 inferior, superiors at the intersection of the inferior thyroid artery with the recurrent laryngeal nerve, and the inferior that descends along with the thymus, which also originates from the 3rd pharyngeal pouch. Due to this fact, the glands can often be found along the descent pathway in the neck or mediastinum. So their most frequent location is the inferior pole of thyroid, but can be with any just along the tract of the thymus, or there may be some ectopic position as well. So for that, we have to know the embryology of the parathyroid system as well. In the most cases, the 4 parathyroid glands located posterior to the thyroid gland, but their embryological migration route opts for plenty of ectopic locations, such as the superior mediastinum, the thyroid, that the gland may be in intrathyroidal, the carotid sheath, and the thymus. By definition, primary hyperparathyroidism is defined as symptomatic hypercalcemia due to excessive parathyroid hormone secretion in the absence of secondary or tertiary causes. So this is definition with, as we are concerned with mainly the surgical part. So I was talking mainly from the surgeon point of view. In literature, single parathyroid adenoma, that is 85% been recorded, 10% for the multiple parathyroid adenomas, and parathyroid hyperplasia in 5% cases and less than 0.1% cases as a parathyroid cancer. Preoperative localization is a paramount, particularly in minimally invasive parathyroidectomy, to determine the site of incision and for the procedure as well. Usually, technician 99 systemic scintigraphy and ultrasound. This is the important investigations. First-line investigation, we all opt for the parathyroid adenomas. We, as surgeons, we mainly focus on the ultrasound, and that I will tell you in the later slides why. But it depends on the operative skills and experience, obesity, small gland size, concurrent thyroid pathology like thyroiditis and multinodular goiters, reoperative cases or previous neck surgery, retrotracheal, retroesophageal, and mediastinal thyroid, parathyroid glands. So there may be, these are the limiting factors in accuracy of ultrasound imaging. Other modalities or diagnostic tools that we used for the parathyroid adenomas are SPECT scan, 4D CT scan. So these are now standard in all of the centers where they opt for the minimally invasive parathyroidectomy. Intraoperative parathyroid hormone. So for the focused parathyroidectomy or targeted parathyroidectomy, mainly the intraoperative parathyroid, that is for the monitoring of the gland, either a gland is excised, specific gland is excised or not. So if that agent is available, so that is used during the surgery. But the quote of John Altupan, who was a professor in George Washington University Radiology Department, in his opinion, the only localizing study indicated in a patient with untreated primary hyperparathyroidism is to localize an experienced parathyroid surgeon. So that's this quote. It's still we use in we surgeons use it almost always who are doing these parathyroid surgeries. For treatment, previously there was a bilateral neck exploration. The neck was the surgeon used to open the neck, explore whole of the thyroid gland, and by visually assessing all the parathyroid. And in his experience, the gland which he thinks that this gland is not normal, so they used to just excise that gland for the parathyroid adenoma cases. But with development of localization techniques and with the development of the 4D CTs with ultrasound mapping, so you can just have a targeted or focused technique like minimally invasive. So that's the newer procedures, which almost always now it's just two decades earlier they have started all minimally invasive techniques. Minimally invasive, focused, targeted, or selective parathyroidectomy encompasses a number of different techniques. That's opening minimally invasive. Just you open it 3 to 4 centimeter by incision. Minimally invasive, radio-guided, video-assisted, endoscopic parathyroidectomies. And the most common is, just I said, it's open minimally invasive 2.5 to 3 or 4 centimeter by incision. It's a mini incision or mini access parathyroid procedures. So the advantage of these minimally invasive procedures is shorter operative time, earlier discharge, better cosmetic results, and reduced post-operative pains. There are some contraindications like previous neck radiation therapy, suspected multiglandular disease, parathyroid carcinoma, or concomitant thyroid pathologies. So the conventional practice of parathyroidectomy has been colon incision, but our local practice involves simplified parathyroidectomy via mini incision. Our diagnostic sequence is same: system AB scan, PTH, and then pre-op ultrasound, And then post-op, at the end of the surgery, after 10 minutes, we used to do after 1 hour, we do a parathyroid hormone. If it is less than, it's decreased by 50%, decreased by 50% from the pre-incision value. So that is the end. Just call it a surgical endpoint. So across the globe, precision imaging and minimally invasive techniques have reshaped the landscape. In Pakistan, we too are navigating this transformation. So we'll go through our journey. This is our brief experience, a journey where small incision meet big aspirations. We have just touched almost 90 cases here in Hyderabad Medical Complex with the minimally invasive parathyroid, but total of 62 I'm presented because of the files which I have at my office. So that in these cases, 62% were female and 37 were male. We did 43 cases under general anesthesia and 19 cases under local anesthesia with a cervical block. So I will show all these later in slides. We did 5 ultrasounds on table for assessment that there was actually, when there's a problem just in the small glands, to locate it, identify it. So we did an ultrasound in 5 cases, and in 3 cases we did PTH levels just on the table. So routinely we do a PTH levels later after the when the patient is finished to the bone. And just in the earlier slide, I said the surgical endpoint is when your procedure, later after the procedure, the PTH level drops 50% from the pre-incision level, and it's called Miami criteria. So that at that time we recognize the excision that we have made that was proper. In our cases, majority of the cases were 56% were the lower inferior pole, and 35% right inferior pole, and then 5 and 3% right and left superior pole. So majority of the cases are left inferior pole adenomas, and that's what we found in the research as well. The majority of the cases are in the left inferior pole, though that's not mentioned. The cause that's not yet established. Our surgical procedure time was mainly 31 minutes. In some patients, like which we done ultrasound or intraoperative PTH, that took time. In our 2 cases, there was a seroma, and 1 cases we have a temporary recurrent laryngeal nerve palsy. Temporary because actually we follow the patient on the first month. That was the second follow-up. So the vocal cord was mobile. Usually, when the parathyroid adenoma produces a lot of PTH, and that makes the normal gland shrunk, so it produces very little. When you remove the parathyroid adenoma, the overactive parathyroid gland is removed. So these the normal produces quite a little for some while, and the PTH remains low for some while. These are early cases what we have done in the early stage of because we used to put a drain at that time. But later on, actually, there is very less bleeding, 2 to 3, maximum 5 ml bleed in whole case. So we don't put any drain now. So this is from our department. Some cases minimally invasive. This is for demonstration purpose. That is marked earlier, the left inferior pole parathyroid adenoma. 1 case endoscopic. We did endoscopic. So it's a pre-op, site of identification. This is post-op scar of a patient. Minimal, it's most negligible to see. We do under local, and that is by bilateral superficial cervical plexus block. So the plexus that supply the thyroid gland and the parathyroid, so that is blocked by our anesthetist. So I will not go in the details of these, all of the block details, but actually it's in cases where we have problems like there are comorbid conditions, so we used to opt for cervical block. With cervical, the patient is awake, and in some cases we give sedation to the patient, otherwise no general anesthesia to the patient. This is our anesthetist for cervical block. There are some complications with that, but we'll not discuss to finish. This is small, it's no bleeding. Actually, if there is 2 to 3, you tie just all the vessels and come to like. This video is streamed 2-3 times just because shorter duration. So just I talked in the earlier slide regarding ultrasounds. Ultrasound, as we consider it, it's mandatory for all parathyroid adenomas. So the reason that in this parathyroid scan, actually the result shows a single parathyroid adenoma in the right lower pole of the right lobe of thyroid gland. But when we did ultrasounds, we have 2 right and left both sides bilateral parathyroid lesions. And then this is the post-op case. In the second case, this person has a 1446 PTH. This one shows parathyroid adenoma just behind the thyroid gland, but it's not visible superior or inferior pole. That we draw lines on this in art to see it where it will be, but still not clear. Most likely to be just at the intersection of the recurrent to the with the inferior thyroid artery just. But when we did ultrasounds, it came up to well-defined hypovascular area inside of the right lobe of thyroid. It's that intrathyroidal parathyroid adenoma. And we just opted for parathyroid adenoma excision, not for thyroid gland removal. It's post-op PTH.
Just 2 minutes left.
And report. So the global trends are early detection, then advanced imaging, intraoperative PTH, and then they opt for the minimally invasive surgery. But we need here to achieve these standards, to have an established registry, invest tools, train surgeons, develop centers to address all these challenges. So my conclusion regarding all my experience is that the preoperative localization is helpful in determining the lesion and site of the incision. Bilateral cervical puncture can be used as a sole anesthetic technique in experienced hands for selected patients, particularly high-risk ones. And excellent results are achievable with simplified minimally invasive parathyroidectomy, even without intraoperative adjuvants. Thank you very much. Thank you so much.
Thanks, Dr. Adnan, for an excellent presentation. Without any delay, our next speaker is Professor Dr. Kashif Shafiq. You are all aware of him. So he's going to talk about biosimilar in endocrinology, scientific and consideration. Thank you.
Ji, Assalamu alaikum. First of all, I'm grateful to the colleagues of Pakistan Endocrine Society who given me this platform to present the biosimilars, the scientific rationale, regulatory framework, and what should be the clinical considerations when we are making the decisions. Just to continue the Professor's Noor Wazir's legacy, I'll start with little apologies again because I have given this task of discussing the science of biosimilars development, so I'll be touching some of the basic sciences at some point. I'll try to keep it simple in the interest of the audience we have here. So before formally starting, I have a few disclosures here. So I have received honoraria for conducting trainings, participating in advisory boards, and delivering educational talks organized by various pharmaceuticals in the country. All of those were enriching experiences for me, but my today's conversation is not going to be influenced by my previous communication. So these were the questions given by the PES scientific team to me to talk about the scientific rationale of biosimilar development, the manufacturing process, how they are developed, what are the regulatory requirements, and do we need separate studies for the biosimilars in terms of approval processes, and are there any differences in terms of scientific efficacy as well as safety, whether it's a recombinant DNA technology manufactured biosimilar or is a synthetic as the pharma claims. And lastly, how about biosimilar can differ from generics regarding safety and efficacy. So just focusing on the questions, basic scientific concept, biologicals are a diverse group of medicine, include vaccines, monoclonal antibodies, and many others. One characteristic feature is basically these are the large sized molecules compared to what we conventionally use in medicines. These are small sized molecules. And one distinguishing feature between biologicals and the medicines which we use is their complex structure in terms of size, because these are refined, purified products, protein products. So their size is larger compared to the conventional medicines that we use. And secondly, they are manufactured through our living system, sometimes bacteria, yeast, human cells, blood, plasma, so a variety of different sources. So in terms of, if you look at the conventional medicines which we use, small molecules, their copies can be prepared easily, not easily, obviously, with some technical expertise, which are called generics. They are chemically and therapeutically pretty similar to each other. But when it comes to a biological, exact copies are pretty much difficult to make because of the natural variations in the biologicals, and that's why they are never identical to the reference product, and they are called biosimilars rather than bioidenticals. These are some of the terminologies which are commonly used for biologicals and biosimilars. So they are biologicals, the original reference product, they are also called biopharmaceuticals and biotherapeutic products, while the biosimilars, they have various names, follow-on biologics, similar biological medicine products, similar biotherapeutic products, and so on. What biosimilars are not, that is one thing very important, because when speaking to the clinical colleagues, they also have some sort of conception about biobetters or biosuperiors. Biobetters and biosuperiors are basically drugs which are engineered to have better efficacy or safety profile. So for these types of drug, if they are engineered to have better efficacy and safety, they require a separate approval process, not just the biosimilars approval process. That's one thing, misconception that need to be removed. So just sort of give you an overview of how the size of these molecules matter. So if you look at the first one here, aspirin, it's only 180 Dalton. Now Dalton is a unit which is commonly used in the chemistry. It's roughly around 1/12 of a carbon atom, or approximately in hydrogen atom size. So 180 up till 300 Daltons molecules are considered as small molecules, and they can be synthetically easily manufactured. The larger the size of the molecule, the more complex the structure is, and obviously the more complex would be the manufacturing process. And here at the bottom, these pictures nicely show, how the complexity is increasing. Bicycles can be easily manufactured, but the helicopters and the aeroplanes would be obviously very difficult to manufacture because of the complexity. So here I will be touching some of the basics now, how this recombinant DNA technology work, what are the manufacturing processes and steps. So let's go back to the biochemistry 101. This is the cell structure. In the middle, you see the nucleus where all the genetic material lies. And that genetic material drives the protein production through the ribosomes. So there are messenger RNAs and tRNAs which take the information from the nucleus, and then they create these various proteins. So the common organisms which are used are E. coli or yeast for the biologicals production. The reason for using these molecules are multiple, but one of the few of those are their simpler structure. So E. coli, for example, have 5,000 protein coding genes in it. Yeast about 6,000 protein coding genes in it. The second is their doubling time. So E. coli can double in about 20 minutes time. Human cells take about 48 hours. Yeast takes about 90 minutes in the rich medium. So their time of replication is important from the industrial manufacturing point of view. So that is the reason these organisms are used. So what initially is done, there's a gene or a genetic footprint or blueprint which is inserted into some of these living cells. And once it's been done, that obviously there are various ways to test whether it's been incorporated appropriately. And these cells and then are given optimal conditions to grow. Initially on the plates, then on the vessels, then on the larger vessels, and finally in the bioreactors, where these proteins are, these cells are produced on a mass level. So this is the upstream process of, producing these cells. Then comes a downstream process where these cells are then lysed, and then all these proteins are now purified. Remember I told you E. coli about 5,000, yeast have 6,000 proteins. We inserted a blueprint into the cell to now create 5001 or 6001 proteins. We're already having 5000, so we added one extra protein into this. So cells have now grown, and they have this now one added protein into it. Then comes the downstream process where these proteins are purified, and there are multiple steps within this where cells are lysed, all the genetic material is exposed, and then various enzymatic processes, chromatographic techniques comes there, where based on the size, the ion, size exclusion, ion exclusion, liquid chromatography, gas chromatography. So all those procedures to identify that one protein, which is being developed as a result of this genetic blueprint. Obviously, this purification process is quite complex. And then finally comes the formulation of that peptide along with some other modification, post-translation modification to use it as a formal medicine. In this process, obviously, there's a lot of complexity. Various factors influence the final outcome of this product. That includes a cell culture medium, temperature, pH, purification processes, and then stabilizing agent. Now remember this, for these products, the original biological molecules, it's the process which makes the product. So process is something which is very critical to understand. Now the regulators in the Western countries like EMA or FDA have strict protocols to look at the process changes if they are occurring on part of the manufacturer. And they consider if there is a change of filter or the equipment is being moved within the facility of the manufacturer, there's a low risk to the product, and then the manufacturer need to submit some analytical and process data. If there is a little bit more modification in the process, like move to a new production facility, but remember, the manufacturer is still the same, they need to provide analytical process and the stability data. And if it's a high risk, if the cell lines are changed or the new formulation have been created within the product. So the changes in the process have a lot of implications for the final product. Now comes the regulatory pathways for these biologicals and biosimilars. They are slightly different from the conventional drugs as well. So these are sort of the timelines when these guidelines were established in the various countries. So EMA, for example, had these guidelines around 2005, and the first biosimilar was registered in 2006. Japan, WHO, and Canada had these guidelines around 2009, 2010. US had these guidelines around 2012, and the first biosimilars were registered in 2015. Since then, there's a lot of improvements and development in these guidelines, and there are group-specific, drug-specific guidelines also being out there. Not only these, but each step of the regulator, for example, what sort of analytical studies or characterization studies are required. So those parameters have also been defined by the regulators in these countries. Now, in terms of the overall requirements from the regulator for these molecules, biosimilar development relies heavily on head-to-head comparisons of the biosimilar with the reference product. So it's not that the independent efficacy of the safety, but it has to be in relation to the actual originator molecule, how these molecules behave. And there are various levels of evidence which is required, the test for quality, non-clinical studies and clinical studies. Within them, obviously, there are a variety of different parameters. But I'll just briefly sort of touch it that it's a step-by-step process. So you have analytical and characterization studies and biological characterization, then the non-clinical evidence, and then PK/PD studies, and finally clinical studies. And the whole of the evidence is seen in totality rather than independent components. So what happens is basically if there are some residual uncertainty on the first stages of the characterization, if the next stages have a more stronger data available, so that can be obviously taken into consideration. But if the residual uncertainty keep building up on each of the step, then obviously perhaps the drug is not a biosimilar. So that's sort of the regulator process. I think this slide better reflects that what is required from the regulator for an originator molecule and for a biosimilar. So if you look at the triangle on the left, for an originator molecule, the more reliance is on the clinical, pharmacological, and clinical studies. But for a biosimilar registration, heavy reliance is actually on the initial phase, the analytical characterization and the biological characterization. There is some weightage for the clinical studies. And at the moment, there is ongoing debate in the West that the clinical efficacy studies should be waived for these biosimilars because the analytical techniques have become so sophisticated that they can analytically find out how similar the product is to the originator molecule. So there is no further need of having these. But that debate is going on, and I think within the EMA and FDA, there are proposals under consideration for waiving these clinical efficacy studies. Now need for separate studies for biosimilars. Well, that's a good question here. I think this is where the WHO's some of these concerns comes in, that one of the main concern, remember I told you that these are purified proteins. Now, once you purify, there are chances of some impurities within these proteins. And the major concern around those impurities, obviously that could be that it can lead to some sort of immunogenicity responses. And then they can develop some anti-drug antibodies. And obviously, in cases of, for example, clotting factors or some other drug, if it's a life-threatening situation and the anti-drug antibodies are formed, that can be challenging for the patient and for the clinician. Now, regulatory guidelines for biosimilars, including WHO's guideline, have clearly stated that immunogenicity of biotherapeutic product should always be investigated pre-authorization. Even if efficacy and safety of SBP and the reference product have been shown to be similar, immunogenicity may still be different. So that is where, again, the role of those clinical studies comes in. There's some evidence already published out there as well. It's not very unusual to have different immune responses from these biologicals and biosimilars. So this is some of the findings from the Element 2 studies, where innovator glargine was compared with a biosimilar, and there were convincing differences between the antibody response between the two groups. There's another one, Solumar, which was a human insulin biosimilar, which was based on pharmaceutical in the United Kingdom, tried to get a biosimilar approval in the EMA, but then there was a difference in the antibody response after 20 weeks, and that then led to the withdrawal of the application and also refusal of the application from the EMA. There have been differences in the biosimilars in terms of efficacy as well. So local insulin, for example, compared with the originator molecule in China is one of these databases, real-world evidence, which show there was a significant difference between the local insulin and the originator insulin. So there are possibilities of having different results both in terms of safety as well as efficacy when it comes to biosimilars. So that need to be taken into clinical consideration when you are making decisions. Now comes the safety and efficacy of synthetic semaglutide as a pharma claim. As of all the safety data that apply to innovators' biological semaglutide, at the moment, that the data which is out there, the robust, good quality data, that's mainly coming from the innovator's molecule. We still need to see evidence of the synthetic biosimilars, how good it is in terms of safety and efficacy. The term synthetic here need to be a little bit clarified here, because if people are thinking synthetic means just the other synthetic molecules or medicine that we have, that might be slightly misleading here. Let me just quickly show you the molecule structure of semaglutide. This is 131 amino acid peptide backbone, which is developed through a biological process. And after that, there is a couple of modifications in it. On the position number 8, there is an amino acid modification where alanine is substituted by AIB, which is alpha amino isobutyric acid, the non-natural amino acid. And the second modification is a C18 fatty acid chain is conjugated with this peptide. Both of these modifications are post-translational modification, and they are synthetic in nature, even in the innovator's molecule. So they are not biological modification. So if people are thinking that this is what the synthetic bit is, that's okay. But if they're thinking that the whole of this peptide chain is also being developed through a synthetic method, I think that is a little bit theoretical at the moment. I have seen patents out there where people have patented these methodologies to develop synthetic peptide chains, particularly for semaglutide. There are 2 patents out there in China. But they are, remember, on the laboratory level. The scalability on the commercial level, that is something that we really need to see the data coming out in the next few months or years. So how clinicians should be deciding about which one to use, the innovator molecule, biosimilar X or biosimilar Y. That's I think quite a hot debate in the country at the moment, particularly in the endocrinology fraternity. So obviously there is no right and wrong answer, but I'll try to sort of make it a more systematic that how we try to look at that. And some of my group members are working on this particular project at the moment with some international partners. So there's a criteria which is called multi-criteria decision analysis. So where we take into account some of the criteria, which are efficacy, safety, cost, immunogenicity, supply stability, and indications. So what we done then was assigned probability to the innovator molecule and this biosimilar for each of these components. And that is the probability of success for efficacy, for safety, for cost. And obviously enough data is available for the innovator molecule, so it was easier to pull that data and fill up those probabilities. You can see the innovator molecule's probability of success in safety and efficacy is high, but its success probability in the cost is obviously pretty low. So that's understandable because of its more expensive drug from the innovator. When you look at the biosimilar of the semaglutide, obviously there's not enough data to fill up the model. What we try to do here is find out some other biosimilars of same size, and we pulled nearly 25 estimates. We meta-analyzed them, and we put those probabilities here based on other biosimilar literature which is out there. Just a disclaimer here, this is the work that is ongoing, and I'm just presenting it. I'm open to any criticism, any feedback about it. I'll be happy to take into account. So once we done these probabilities, we then normalize these for both for the innovators and the biosimilar. So, and then what the next level is that the normalized score is multiplied with the weight that we have assigned in each of the components. So here are those calculations. And just to get the final score for the innovator and the biosimilar, particularly in Pakistani context, taking into consideration the semaglutide's innovator and the reference the biosimilar, and these are the scores that we got. So 0.767 for the innovator, 0.74 for the biosimilar. So it seems quite competitive at the moment, but obviously this model and the result will change as the probabilities of the innovators change, or we give or assign different weights to each of the category. We also try to rerun the model with a few modifications where we given more importance to the safety and efficacy. So 5% more weightage to the safety and efficacy, and the scores of the two groups then became a little more different. Then we ran a third model where we given more probability to the success to the cost rather than the safety and efficacy. So we obviously have patients which are cost sensitive, and that's the scores when we got. So priority just changes in favor of the biosimilar. So this is how we try to look at that in the present context. Just to summarize the MCDA models finding, the innovator drug, the semaglutide, slightly outperformed the biosimilar under the given weights. Obviously, these weights can change once we have more robust data coming from biosimilar side. However, the biosimilar remain competitive, especially in the cost-sensitive scenarios. Adjusting weights can shift the preferences. Now, weight sensitivity, priorities, whether safety versus cost, heavily influence the outcome. Clinical context is the high-risk patients favor the innovator, cost-driven systems may prefer the biosimilars, and the sheer decision-making based on the MCDA to align stakeholders' priorities with evidence-based choices. So final recommendation is validate the weights with the local stakeholders and with the local evidence once they start coming in. So my final conclusion is that unlike generics, biosimilars are not identical to innovator products. Regulatory approval require analytical, non-clinical, and clinical studies to ensure similarity. The clinical comparability studies for licensing of biosimilar need to show that no clinically meaningful difference in safety and efficacy exists between the biosimilar and the reference product. Even clinically equivalent biosimilar may show different antibody response impacting long-term safety and effectiveness. Regulators emphasize mandatory immunogenicity testing pre-authorization. And finally, the clinical decision should be balanced by factoring into efficacy, safety, immunogenicity, cost, and supply sustainability. Obviously, I'm not taking into account all those patient-related factors as well as the regulatory environment that is in place in our country. So once you place those factors into the model, results might be different. So thank you so much. And thank you once again for the PES for giving me this opportunity.
Dr. Kashif, can you stay there for a 2 minutes? There are two questions which we...
Oh, straight away?
One question is, looking at your lecture and availability of biosimilar here, should we not be more worried for safety rather than efficacy?
Well, I think that's a brilliant question. I mean, if I'm in for example, in Europe or in the United States, and if a biosimilar is registered, obviously I would have a lot of reliance on the regulators' part that it's a good job being done. But considering the history of, unfortunately, inconsistencies in our regulators process, I would be, for my own patients and my own family, I would be concerned for the safety rather than the efficacy.
Okay, the next question is how much minimum number of patients needed in trial for biosimilar molecule approval in new facility?
So it depends on what is the outcome that we are looking at. So depends what indication that we have, and then obviously the selective group of patient and the sample size is going to change based on the endpoints that we are looking at. Is it just the safety, efficacy, or what particular indication is that?
Okay, so your part is another question from Professor Noor.
Thank you.
What about legal aspect of using artificial intelligence in diagnostic and treatment in case any issue arises?
Um, Very pertinent question, particularly the ethical and legal, issues related to text or treatment suggested by ChatGPT or any other, application. Well, the algorithm, and this is the main issue, the algorithm who has developed the algorithm, they, if you ask them, and this is very important because this is the backbone, and it needs, explainability, and at the same time, um, reliability, that is reliable, and transparency. But if you ask them, they would say it is our trade secret. And number two, if we try to explain it, you are not going to understand it, right? So whatever you do, ultimately you are the one who is going to take the responsibility, whether it's the text, whether it's the treatment, not, ChatGPT or DX, etc., etc. But having said that, those which are approved by FDA, regulatory authority, those who have got HIPAA, license, they are pretty reliable, and the regulator has gone through the pilot projects. But that's an issue.
Okay.
The world has to face.
Thank you. Thank you. It's excellent explanation.
Similarly, regarding, say, a text generated, at the moment, internationally, there is no, for plagiarism, we know in many it is 20% acceptable. But for AI generated content, internationally, there is no cutoff limit. Although here in Pakistan, most of the journal, they would put up the same cutoff limit of 20%, but internationally there is no cutoff limit, that if your manuscript has got this much text generated by AI, it is bad.
Okay, thanks. It's excellent explanation. Professor Abdul Basit, want to summarize the things? नहीं, उनके नहीं, दो के.
Thank you. It has been a very great session, and we had some what we can call is new items on the agenda, and hopefully for progress like AI discussion, biosimilars discussion, how to establish a diabetes clinic. All were really those topics which are pertinent to us, and I hope the audience would have benefited from it. The only thing which I would like to touch on here is about how to establish a diabetes clinic. I think we are now in a position to develop a national diabetes program. Enough was detailed by Hamid. We know many of the colleagues who are here who are running part programs, you can call it, or provincial programs, or public-private initiatives. So we are very optimistic. If we continue this momentum, a time is not too far that we shall have a national diabetes program with national diabetes registry in place, national structured curriculum for healthcare physicians, educators, allied healthcare professional bodies to regulate the allied healthcare professionals, multidisciplinary team, then the support from the corporate sector for affordability and accessibility. So I think, yes, we are moving in that direction, and Pakistan Endocrine Society as a whole and other stakeholders shall be given full marks and a round of applause for closing the session as well. Thank you.
I will ask Dr. Yaqub Khan to come for moderate in the next session. Dr. Yaqub Khan, thank you.